after a procedure, it's not unusual for there to be a little bit of blood there. So if I send you to the ICU, don't be alarmed. If you're awake and alert, you're doing just fine. Okay. The pathologist will be able, the goal is to have the pathologist to tell me that I'm in the target tissue. Okay. Sometimes they can render an initial impression like this looks to be a tumor of the brain. If it's this demyelinating thing, I frequently get I don't know what I'm looking at right now, but you're in the target area. But it can take 5 to 7 days for them to stain for demyelination and to give a definitive diagnosis with that. If it looks like it's a tumor, then I'm going to need to get you working with one of our oncologists here to come up with a plan that typically involves a combination of radiation and a pill chemotherapy. It's not one where you have to go in for an infusion frequently. If it is a demyelinating process, then it's more of I need to get you working with the neurologist for kind of an anti-inflammatory protocol of medications. The procedure, generally, the actual operative time takes about 15 minutes. There's a lot of kind of sitting on my thumbs waiting for the pathologist to render an opinion. I don't de-dock the system from you until I've spoken with them and they say, this is what we got, okay? The hole I cover up with a little titanium plate that looks like a snowflake, and it will attach to your native skull through the use of these little 4mm titanium screws, okay? The risk, as I told you, really the primary risk is bleeding at the biopsy site. There's always a risk of bleeding in general, but if we ever had blood loss to the point where I needed to transfuse you, I better be able to explain myself because I've never had to do that before, and that would be very uncommon, okay? Infection, obviously I'm leaving a metal plate behind. It can always get infected, but the scalp is a very vascular structure. It tends not to get infected, okay? Other than that, in terms of how long you will be in the hospital, kind of depends on what the diagnosis is, what we think we need to do, things like that. Maybe through the weekend, maybe discharged at some point over the weekend. It just kind of depends on the outcome of the procedure, okay?
What's recovery like?
Well, the recovery from the biopsy, I mean, you'll be up and walking around. It's by and large, people don't have a recovery period for the biopsy itself. In the world of kind of minimally invasive, it's about as minimally invasive as brain surgery gets. Okay.
The surgery that removed a piece of my skull.
The
surgery that removed a chunk of my skull, what's the recovery for that?
That is, you're going to be up and moving around. You're not really going to detect a missing piece of your skull. It's very, very small.
And that'll heal relatively quickly.
Yeah, the bone will never completely grow together and smooth over. You'll always see, at the very least, see a divot in the skull and most likely a residual hole there. But, I mean, it's not like people develop, I've never seen anyone with a penetrating injury at the site of a burr hole or anything like that. So.
Did you know that he had a tumor on his shoulder when he was little?
Yeah, that was a chondrosarcoma, right? Or osteochondroma, pardon me. Yeah, this does not look like that, and osteochondromas don't occur within the substance of the brain, so I think we're dealing with something different. There's not a link between osteochondroma and this either, so this is a acquired tumor just at some point. If it is in fact a tumor, it would be a spontaneous mutation type of thing.
Nobody knows why, right?
No, I don't want to go too far down that road, saying it's a malignant brain tumor, but what we have found is as our technology has increased with the amount of Wi-Fi and stuff flowing around, we have detected more of these. Now, is that because our technology has increased to the point where we're able to detect them? It muddies the question. But yes, the amount of ambient radiation in the environment does raise a concern.
Yeah.
So when do we do this?
So I'd like to put you on. We've got cases tomorrow morning and kind of midday, and I'd like to put you on in the afternoon. I think right now it's tentatively around 2 p.m. That's going to be a bit of a moving target because we, can only become so accurate in how long it takes to do the cases proceeding.
Once started?
So once it's started, it's actually about 15, 20 minutes of operative time, but it can take upwards of an hour to wait for the pathologist and whatnot.
And depending on the results of the pathology, you might need to go back in?
I really am not a big fan of that. I like to answer the question before we walk out. That's why I leave that system docked to you to take further samples. And so I don't really like that. Now, if it comes to the point where I feel I'm endangering you by taking more unvisualized biopsy bites, okay, I will, and we'll have to come back and revisit, is there a better spot to biopsy? But this thing extends out in the left parietal lobe a little bit. That's the best target to do. I have to go through the least amount of brain to get there and things like that. And it's got the most enhancing tissue, which generally correlates with the best biopsy target.
And so while this thing is docked to me,
Mm-hmm.
what is my anesthesia state?
So you're completely asleep. Okay, the machine is breathing for you,
Mm-hmm.
and you are paralyzed, medically, chemically paralyzed.
And
That's a
what
good
are the
question.
chances that I have one of these freak occurrences where I'm awake but I'm paralyzed?
So we've never had actually, so I use the same anesthesiologist all the time. We've not had a single incidence of recall, okay? Typically, neuroanesthesia tends to run people deeper than other types of anesthesia. I've actually never, even in my training, been involved in a recall case, okay? There's always some remote chance, but I would say, given the number of cases that we have done and whatnot, that is in the fractions of a single percentage point.
Okay. Oh, sounds great.
Well, it is what it is, and I think this is the best move forward. We need to get a diagnosis of this. We know if we leave it alone, it's just not going to work out. So
All right.
Well, it'll just keep growing. The
that's my
lady
worry.
Said that it could do anything because it's going down the.
Well, it's got access to multiple pathways in the brain, so that's kind of the way to think about the splenium of the corpus callosum is like the high five. A bunch of roads go in a bunch of different places. So
Is that what John McCain had?
glioblastoma is what John McCain had. Yes.
That's a possibility here.
Yes.
And so the goal, once you determine, if you determine that's what it is, what would happen after that?
Dependent on the diagnosis. So if it turns out it's a malignant brain tumor, then it's get you working with the oncologist, talking about a plan for chemotherapy, radiation.
And if it's benign?
And if it is a benign lesion, depending on what type of benign lesion it is, that's the area that you would go. The most likely, in my view, would be that tumefactive demyelinating plaque. That would be getting the neurologist involved, the medical version of me. So I'm like a cardiothoracic surgeon, then there's a cardiologist who handles the medical management of the heart. That's kind of what the neurologist does as well. And that would be types of medications to blunt the immune response causing the demyelination.
Because I have had benign tumors
Mhm.
in my past.
Mm-hmm. And that's definitely in the differential, and frankly, that's what I'm hoping for. Okay?
Well, I guess we just charge on forward.
Yep. I agree. Any questions?
I don't think so.
What's
Okay.
the recovery going to be like for this?
You're going to be up and walking around pretty quickly afterwards, like even
I had
the
a
day of.
biopsy on my pelvic
Mhm.
marrow, and that was not, it wasn't pleasant, but it wasn't that bad of a recovery.
I bet you the recovery for that's even harder than this.
Okay.
Those things don't feel good when you get a needle stuck in your pelvis.
It was more like a drill.
Yeah. Yeah, that's good word choice, right? When I say needle. Yeah. No, I would agree with you.
Okay.
Okay?
All right.
Alrighty, guys. So I will probably see you down in holding tomorrow. As we're finishing up the case before you, I'll say call for Mr. Ash. And I'll see you guys down in holding before surgery, and we'll kind of go over things again, make sure that y'all are clear as to what the plan is, what the risks are, and then we'll take off from there. Okay?
Thank you.
Alrighty, guys. Any other questions?
Not right now.
Did I mess this up? Nope, I didn't. It's still recording. So it's in 2 videos.